This is the postgraduate pediatric orthopedic video series. I'm Satal Shraid. I'm a pediatric orthopedic surgeon.
In this video, I'll take you through the technique of femoral osteotomy for Legg-Calvé-Perthes disease. And this is part of chapter 4 for the postgraduate pediatric orthopedic book. We recently published our video on Legg-Calvé-Perthes disease in general, but this video is about surgical technique for the femoral osteotomy. However, we would like to refer to a few points from the last video. The first point is that containment, which is the mainstay treatment for Perthes disease, can be achieved for physiotherapy, braces or casts, femoral osteotomy, pelvic osteotomy, shelf acetabuloplasty, a combination of the above, and hip distractor. And when we looked at the literature, we found there's really no difference between them in terms of achieving a similar outcome for Perthes disease. My favorite option is femoral osteotomy for several reasons, including that the pathology is in the femur, so it is logical to target the femur. It is technically easier and can be accurately fine-tuned to achieve good containment, unlike the pelvic osteotomy, which has limitation. It reduces shortening, which is useful, while pelvic osteotomy produces lengthening. Drilling the neck theoretically stimulates healing, and if the femoral osteotomy or Varus osteotomy does not remodel with time, we can easily correct that. Benjamin Joseph published a nice paper about the effect of femoral osteotomy on the natural history of Perthes disease, and it shows that 34% bypass the stage of the fragmentation if it was done before the fragmentation stage. Also, it noted that duration of the disease was shorter in these patients. The duration of the stage of the fragmentation was reduced in operated children who passed the stage of fragmentation. So the indication of femoral osteotomy is based on age, stage of the disease, and hip extrusion. And if you recall from the previous video that children who are above the age of 7, we aim to do the femoral osteotomy as early as stage 1A. So the moment they present it to us, we do femoral osteotomy. If they present late, or if they're under 7, we can watch them till the head starts extrusion, and if it starts extrusion, no matter what age they are, we do femoral osteotomy or any containment surgery. A common questions I get asked, and even you might get asked in the FRCS exam, is that how much Varus you'll do in these children. There's a controversy about that, but there's a nice paper published by Kim in 2011 in the JBJS. It showed 20 degrees of Varus is usually sufficient. And they stated that excessive proximal Varus can produce limb shortening, it can cause abductor weakness, abductor lurch, and overriding greater trochanter, which might cause lateral impingement. There's controversy about this area, and I believe good containment is important even if it exceeds 20 degrees. However, the juries are still out. In Kim's paper, in 66 patients, he found no significant correlation between the postoperative neck shaft angle and the Stulberg outcome. One of his interesting findings is that the significant relationship that was observed between the lateral biliary group B and the Stulberg outcome. What he found that the higher postoperative neck shaft angle, the greater probability of being associated with the Stulberg class 1 or 2. Which is really difficult to explain when we think about Perthes disease. So let's go back to our case presentation. It is about an 8-year-old boy who presented with limping, groin pain radiated to the knee, no constitutional symptoms. His blood tests, x-rays, and MRI scan, which were done in an outside center, were consistent with Legg-Calvé-Perthes disease. The x-ray showed typical features of Perthes disease, with the head is sclerotic and denser in color in comparison to the other side. Also, it is smaller than the other side, but still there's no fragmentation. So this is stage 1B. Also, we can see metaphyseal cyst there. And if we look at the head is starting coming out of the socket, we can see if we drop a perpendicular line from the outside of the socket, we can see some of the head is outside in comparison to the other side. But also, if we measure the distance from the base of the acetabulum to the medial side of the femoral neck, we can see this distance much shorter than this distance. In fact, when we measure it is 8 mm on the normal side in comparison to 15 mm on the other side. Given his age and given the radiological finding, we offer the child a surgical correction in terms of femoral varus osteotomy, but they declined the offer at that time and they wanted to go for non-operative treatment. They came after 2 months and the head started fragmenting here, and we can see the distance, the head extrusion become even bigger. At this stage they wanted the surgery. In theater, first we do EUA for the hips. This is really important. First we need to see the true neck shaft angle, because the preoperative or the departmental one, they are not always give you the exact measurement. Here we control for rotation, and as we measure it here, it is 133 degrees. Then we'll see how much abduction we have, and we measure how much abduction to achieve good containment. Here we need around 13 degrees to achieve a good containment. Then we will check for how much abduction we have, whether there's tightness in his adductors, which is not an uncommon in children with Perthes disease. In this child, I felt he was a bit tight. I cannot achieve much abduction. Putting in mind doing varus osteotomy is going to worsen his abduction contracture, so I plan to do a ductal tenotomy on him at the end of the procedure. And my favorite fixation device is the Pediatric locking proximal femoral plate from Orthopaedics. And here the common questions to residents or fellows also appear in the exam, how to achieve the correction you want to achieve. There are two ways, what I call it the crazy way or the easy way. The crazy way is to use the calculated angle. Here first we need to determine the correction angle, which is the difference between the current neck shaft angle and desired neck shaft angle. We knew the current neck shaft angle is 133 degrees and we need to correct it by 13 degrees, so we need to aim for neck shaft angle of 120 degrees. So the first step is really to measure the correction angle, which is the difference between the current and the desired. As we said here, it's going to be 13 degrees. Then the second part, you have to choose your plate, whether 90 degrees, 100 degrees or 110 degrees. And suppose you're going to choose 100 degrees, then you need to add the 100 degrees plus the correction angle. Therefore, the calculated angle would be the correction angle plus the plate angle. In our case, we have the correction angle of 13 degrees plus the plate 100 degrees. We'll have 113 degrees calculated angle. After that, use this calculated angle to set your jigs, and there are two jigs provided by Orthopaedic. One is fixed, which is the bottom lower corner, and the other one is adjustable, which is the top right corner. So this is basically what I call it the crazy way. The easy way is much simpler. Based on our calculation, we needed the desired neck shaft angle of 120 degrees, so simply use 120 degrees plate, but ensure that the initial guide wire and subsequent screws remain exactly in the middle of the neck of the femur. Another question you might get asked in the exam is the offset, the purpose of the offset and how many millimeter of offset would you use. The purpose of the offset really is to restore the mechanical access to normality. And normally the mechanical access that goes from the center of the hip to the center of the ankle should pass through the center of the knee. However, when we do varus osteotomy proximally, this will move the mechanical access more medially. In another word, it causes varus, as we can see in this diagram. So by shifting the distal fragment of our osteotomy more medially, that would restore the mechanical access into normal as represented in this diagram. And the more varus we do, the shorter the limbs are, the more offset we need. And now we go back to complete our surgery. We position the patient supine on radiolucent table. We prep the lower limb from the belly button down the feet using chlorhexidine. We put stockinette around the foot and we split drape to seal the operative site. I usually use IOPAN to seal the end of the draping to prevent it coming off during the surgery. And we prepare our diathermy, both monopolar and bipolar, and suction. Just before I start the surgery, I do another preparation using chlorhexidine. I feel this is important just in case we contaminated the surgical field during the draping. Then we mark the area. 3 dots, one the anterior part of the trochanter, one posterior, and one the top. Then we draw our surgical incision. To demonstrate the surgical procedures closely, I borrowed this video from another patient where I have a closer look up and my head doesn't come in the way. So we make the incision along our surgical line that we drew earlier. I usually start with a knife just to cut the skin. Then after that I use a diathermy. Here I'm stopping some of the bleeders. Then we cut through the fat. To cut through the fat, you need to put the fat under tension, otherwise the diathermy doesn't cut. And my assistant, they grasp all the bleeders and I buzz them as I go along. And you can't tell the difference when you use the diathermy. Almost the field is bloodless. That's why I prefer the diathermy. Here I'm extending the incision a bit. I don't normally peel the fat off the IT band, but once I reach the IT band, I make a small hole, and you can see the IT band just slight whitening at the bottom of the wound. Here I use the knife just to open the IT band, a small hole in the IT band. Then my Mayo scissor, I cut it distally and proximally. Here, if it is tight, your assistant can slightly abduct the limb to make it easier to cut back. When you come proximally, the IT band is very thick and sometimes the scissor might not cut through it. Either you need a bigger scissor or use the knife. Smaller bleeder, we need to stop it. Here I use the knife because the IT band is quite thick here. You can see the bursa, the trochanteric bursa coming in the view now. Again, I peel off the bursa. And take your time at this stage, there's no rush. Try to find the attachment of the hip abductors or the abductor medius and minimals. Because this will be your landmark where you're gonna cut your vastus muscle. Here I'm almost there. Trying to clear more proximal. And ready to find the hip abductors where they attach to the greater trochanter. And you can see here I reached that. And this will give me my landmark to divide the vastus of the femoral bone. I'm cleaning it a bit more so that I have a better visualization of my anatomy. Here my assistant pulling the skin away from the surgical field, and you can see this is the hip abductors where they attach to the greater trochanter, and my division of the vastus will be along this one. I usually use the diathermy here, and I will cut full thickness of the vastus all the way down to the bone. Usually get a bleeder down at the posterior angle. You stop it with the diathermy. Then you can see at the bottom is where the gluteus maximus attached to the bone, and this tendon also blend with the lateral intramuscular septum. So you need to peel the vastus lateralis off this. It's really important not to cut through the vastus because it de-innervates the muscle. So here I'm cutting exactly behind the vastus and lifting like a triangular flap of the muscle of the bone. And here when I lift the muscle with the periosteum together. Once I've done the first part, I can use my periosteal elevator to peel more of the muscles from the bone. As I said, this video has repeated I think 3 times, 3 folds. That's why you see the movement quite shaky. Here I'm using the periosteum to peel off more of the periosteum of the bone, and I will go more medially because my osteotomy is going to be here. As I see, as I peel off, I put my bone lever so that I can see where the periosteum. It is important to stay subperiosteal to keep you safe when you do your osteotomy. Unfortunately, the angle of the camera doesn't show the front of the bone very well, but this should be done under direct vision. You put your bone lever, lift it up, see where the periosteum is, use your periosteal to peel it off till you reach the medial side. And as I said earlier, try to peel off the vastus lateralis of the intramuscular septum, which is a white structure behind the vastus you can see in this video. Take your time because here there are important perforators. These perforators, you should identify them before you cut them and stop them, because if you don't do so, they might retract behind the intramuscular septum and it will be difficult to stop them then. So take your time, really take your time. As you see, I can peel a millimeter at a time and I look for any perforators. When I reach to the periosteum, I cut it completely to the bone. Oops, this is one of the perforator. Luckily it was just pierced from one side, it has not retracted behind, that's why it was easy to stop the bleeder with a diathermy. Then down to the bone. Once I reach enough length, I use my periosteal elevator to peel the tissues of the bone, front and back. If you plan to do derotation as well, depending which direction, you need to peel that bone in that area. For example, if I'm planning to do external rotation of the distal fragment, I need to peel off the front of the bone. If I'm planning to do internal rotation of distal fragment, I need to peel more of the posterior. In children who have Perthes disease, I usually aim for little rotation to bring the anterior part of the femoral head more anteriorly. Now I think I almost got enough bone both distally, anteriorly and posteriorly. Again, you don't need to struggle in these one, get extra length so that the whole procedure will go smoothly. If you use a small incision, you might struggle. Again, I'm going back to my osteotomy side, I peel posteriorly or anteriorly. Once I'm happy with my exposure, I use my initial wire to go through the neck of the femur and I check this in the X-ray screen, both on the AP and the lateral. And they aim slightly high on the AP and in the middle on the lateral. I'm happy with this position here and I'm happy with this position. So then I move to my jig. Orthopaedic provide a nice jig which you can screw the 3 towers or 3 guide to them and you can put it. Again, you can direct it with the anterior or posterior. My guide wire go in the middle hole. Then I use the other guide wire, which is usually thicker. Usually I use 2.5 or 3.5 per plate. Please read the manual so that you know which wire you use and whether you need to drill it or not. So I put my 3 guide wire. I don't put them fully to start with until I check them with X-ray. When I'm happy with the X-ray, I can advance them a bit more. See, this is the 3rd one. As you can see, they are not fully advanced. Now I'm advancing them a bit more because I was happy with the X-rays I've seen. I'm so sorry I didn't save these images to show you, but I'll show you the pictures later with the screws. Here I'm happy, so I pull my jig out. Although some people prefer to cut over the jig, I don't like this option because I don't see the bone very well. I normally prefer to put 2 bone levers on either side of the bone and cut the bone under direct vision, as you can see in this video. I put my bone levers, but I forgot to put my rotation wire to ensure my rotation doesn't change or it changed at the amount I want. So here I'm going to put the anti-rotation wire. Here's my rotation wire. 2 mm I usually put it proximally and another 2 mm distally. I make them parallel to each other. Once I put them, then I can do my osteotomy. I usually check them. Here I'm checking they are parallel to each other. Here I cut it just a few millimeters below the lowest wire. Bone in children is very vascular, so when you cut the bone, usually they bleed a lot. If I'm doing bilateral or multiple bone osteotomy, I ask my anesthetist at this stage to give tranexamic acid, usually 15 mg per kg. Also, you noted that my assistant squirting some water on the bone to cool it down. Sometimes I use osteotomy to break the medial cortex. I feel it is safer than using the saw to cut all the way through. Now I can see my osteotomy completely free, and I free it more. I ask my scrub team to put the guides and screw it to the plate. Then I feed the plate along the guide wires all the way down to the bone. Here you can see my plate sitting really flush on the proximal fragment, but the distal fragment is not translating very well medially. So I'm going to pull my plate slightly outside to make sure that the bottom of fragment go in the right place. Just freeing some periosteum, then I push it back. Now it sits much better. Okay, I'm happy with that. I measure the top screw, and because the size of the drill is the same size as the guide wire, 2.5, so once I measured it, I removed both the guide wire and the guide. These are lock screws, so I usually use them on power. And this is the first screw. It's important when you put the first screw, you squeeze, you push the plate down all the way down to the bone, because once you lock it, you cannot do this anymore. And I'm happy how it's sitting really nicely on the bone. Then I do the same with the other 3 proximal screws. Measure, remove the guide wire, remove the guide itself, then put the screw using power. The bottom screw, the bottom of the 3 is really important, because this is what it determines your flexion or extension of the distal fragment in relation to the proximal fragment. So make sure that you put it in the right place. If you don't want any flexion or extension, you have to put it in the center of the bone. Again, this is the last screw now. We measured it. Remove the guide wire. The guide wires are thready, so you better remove them on reverse. And you put the screw. And when you put the screw, use power, because it will speed you a lot. But the final threads, I mean when the head thread reach the plate, use a normal screwdriver, which is ideal with torque wrench. And the reason for this is really to prevent cold welding, where the screws really become part of the plate. Now I'm happy with my proximal fixation. It seems to be solid and the plate down to the bone. Now I move the distal fragment now to the bone. Orthopaedic have a very nice bone holding clamp. It has a knob that fit to one of the holes of the plate, and it grasps it very well to the bone. Here I'm trying to reduce it, maintaining my rotation and maintaining good Varus osteotomy. Here I'm happy. Now I'm squeezing my bone. Seems to be a good hold there. I checked my rotation is good, and also I checked the amount of Varus we achieved by this, and seemed to be 121 degrees, which is almost within 1 degree of what we wanted. Then we put our first screw. Our first screw should be no locking and in compression mode, so that it compresses the osteotomy site. And now we have drilled the bone, measure the size of the screw, then we screw it in. The second screw will be a locking screw. That's why we have to put the tower or the guide to the blade, then we drill. We can use the same drill to measure the length of the screw, or we can use a depth measure. And again, here we put the locking screw. Fortunately, the pictures or the angle of the camera is not showing, but basically I'm putting the second, which is a locking screw. Then at this stage, after putting two screws, we can remove our bone holding clamp, and we do our final screw, which is a non-locking in a neutral position. Again, after drilling, we measure the size of the screw, then we put the final screw. Here we completed all our screws, and my check X-ray is reasonable both on the AP and the lateral. Then I turn my attention to how much abduction I have. As I mentioned earlier, doing Varus osteotomy will tighten the abduction, and from my initial EUA there was already tightness in the adductor muscles. So I decided to do percutaneous release of adductor longus. You can do open if you want, but in a big child like this, it's fairly straightforward to do percutaneous release. And you do by feel. As you can see, my middle finger and my index finger usually feel in the tendon. And usually this give you another 20-30 degrees. I'm happy I release all the tendinous fibers, and there's no bleeding. I go back, I wash my wound, and I start my closure. Again, for better clarity, this video I borrowed from another patient, but it is the same step. Here we try to close the vastus lateralis to its anatomical position. Just to orient you, the head is going to be on the left hand side. We're using Vicryl number 1, and we try to suture the posterior angle to where it comes from. Closing or restoring the vastus lateralis to its anatomical structure, it serves many purposes. Number 1, it provides a good padding for the blade, so when the child lies on their side, they don't feel discomfort. But also later, when you remove the blade, it will stick back to its position, and this restore the function in a better way. Again, I prefer to go from the posterior to anterior, and sometimes I do double breasting. I go back to the same in the reverse direction. Try not to do excessive force, because sometimes these suture can cheese through the vastus or the other side on the trochanter. Take your time. Sometimes you can ask your assistant to use Alice or any tissue forceps to bring them together so that there'll be no much tension. I tie my knot at the top, then I go back again. And when I go back again, I usually use a different plane to close the top part of the vastus. This will give a stronger repair. Then I'll repair my periosteum and its attachment to the intermuscular septum back to the back of the vastus lateralis. And some people don't bother to do this step because the vastus already secured at the top, but I prefer when you close it, it will give a nice feel for the whole repair. And again, it doesn't take long time, probably 2-3 minutes. Here my assistant is slightly giving me some abduction to ease the tension so that I can repair it easily. Go as distal as you can. once I'm happy, I tie my suture. Then another washout. I usually keep a washout every layer I finish. Then the next part we'll do the IT band. You can start proximal or distal, it doesn't matter. But this needs to be prepared properly. If you don't, it might leave holes, and muscles can herniate these holes and it can be painful. Also make sure that you don't stitch the IT band to the vastus. These two structures, they move at different speed, and if you do that, it causes very painful tethering. The technique I like is top to bottom, because you can put your forceps underneath the IT band on top and you slide your needle. Unfortunately, my head in the way here, you don't see it very well, but I hope we can get a glimpse of that. No, unfortunately my head is still in the way. Yeah, here. Yeah, so you put your forceps and slide your needle, and you're sure you're not taking any tissues. The bottom one you do under direct vision. And we finish off with fat and skin. I'm so sorry I skipped some of the steps for the sake of time, but this is a pretty standard. When we finish the closure, we use stir strips, and if the anesthetist didn't give any caudal, we usually infiltrate the wound with local anesthesia. Then we dress the wound with, in our hospital we use Mepilex, but any other similar dressing would do. Postoperatively, the patient will have postoperative analgesia, usually opioid, 2 doses of prophylactic antibiotics, and he will be non-weight bearing for 6 weeks. Physiotherapy will start immediately after surgery with active and passive range of motion, and the patient will come to clinic in 2 weeks time for wound checkup. These is x-rays, the last x-rays he had, and almost he's in stage 3B, and seem to be heading toward Stulberg type A, maybe B. And this will bring us to the end of our video. I hope you find it useful. Please, if you haven't watched our first part about Legg-Calvé-Perthes disease, do watch it, and we wish you all the best for your exam.